Hello and Assalamualaikum to Miss Faika and everyone. My name is Sharifah Azima Binti Allam Halim Shah, and today I'm going to discuss about the image evaluation of two projection of the femur, which is AP and lateral projections. I'm going to evaluate them according to the placement guidelines, which is the projection, positioning, alignment, collimation, exposure factor, marker, and aesthetic and name. This is my image of femur AP. For the projection, this is a radiograph of an AP projection of the femur. I say this is a projection of the femur because the mid-femoral shaft is at the center of the exposure field, and the head and neck of femur until knee joint is included in the exposure field. And I say this is an AP projection because both of the femoral epicondyles, medial and lateral epicondyles, are in profile, and the greater trochanter is in profile laterally. Next, for the positioning, I've divided the criteria for the positioning into two parts, which is positioning for the distal femur and the positioning of the proximal femur. These are the positioning criteria for true AP of distal femur. The lateral and medial epicondyles of femur is in profile, and the femoral epicondyles are symmetrical in shape, meaning that both of them are in the same size. And the intercondylar eminence is centered within the intercondylar fossa. We can detect the mispositioning at the distal femur by looking at the sizes of the condyles. If the leg was too externally rotated or laterally rotated, the medial femoral condyle is seen larger than the lateral condyle. And if the leg was too internally rotated or medially rotated, the lateral femoral condyle is seen larger than the medial condyle. So this is the positioning criteria for true AP of the proximal femur. The femoral neck is seen without foreshortening, and the greater trochanter is in profile laterally, and the lesser trochanter is superimposed to the femoral neck. We can detect the mispositioning of the proximal femur if there is a pelvis rotation by looking at the superimposition of ischial spine and the pelvic rim. And also we can look at the obturator foramen. When the pelvis has been rotated toward the affected femur, the ischial spine is demonstrated without pelvic rim superimposition. And the visualization of the obturator foramen is decreased. And when the pelvis has been rotated away from the affected femur, the ischial spine is not aligned with the pelvic brim, but is demonstrated closer to the acetabulum. And the demonstration of the obturator foramen is increased. Besides pelvis rotation, mispositioning at the proximal femur can also occur if the foot is incorrectly rotated. This is the proper foot rotation where the foot is internally rotated, then the lesser trochanter will not be in profile and it will superimpose with the femoral neck. And if the foot is externally rotated, the lesser trochanter will be in profile medially. So this is my image of AP femur. The positioning for this projection is incorrect, meaning that the patient is not in true AP. This is because the femoral neck is seen foreshortened and the lesser trochanter is in profile medially, and the intercondylar eminence is not centered within the intercondylar fossa. To improve this, we should internally rotate the patient's leg up to 15 degrees. For the alignment between X-ray tube with cassette cannot be determined because there are no four borders of collimation, and the alignment between the patient with cassette cannot be determined because there is no four borders of collimation, and the alignment between X-ray tube with patient is incorrect because the distance between the central structure, which is the midshaft of femur, to the edges of film at the left and right is not equal. The centering point for this radiograph is cannot be determined because there are no four borders of collimation, and the standard centering point for this projection should be at the midshaft of femur. Next, for the collimation, at the superior border, structures that should be included are femoral head, femoral neck, and greater trochanter. And at the inferior border, structures that should be included are lateral epicondyle, medial epicondyle, and intercondylar notch. At both lateral border, structures that should be included are greater trochanter, lateral epicondyle, and femoral neck. There is no evidence of radiation protection apparatus seen on the radiograph. Next, for the exposure factor, the KVP used for this projection is adequate. This is because the bony cortical outline of the thin structure, which is the greater trochanter, and the lateral epicondyle can be seen, and the bony cortical outline of the thick structure, which is the femoral head and distal femur, can also be seen. And the MAS use is adequate. This is because the bony trabecular pattern of the thin structure, which is the greater trochanter and lateral epicondyle, can be seen, and the bony trabecular pattern of the thick structure, which is the femoral head and distal femur, can be seen. There is no action needed to improve this. For the marker, the plumber marker has not been applied at the time of exposure. The marker in the radiograph is not legible. The marker is in the correct position, and the marker should not superimpose any region of interest. For the aesthetic value, the film size used for this radiograph cannot be determined, and the standard film size for this projection should be 35-43 cm. There is no evidence of artifact on the radiograph. For the name, there is no ID and information of the patient. It is to protect the patient's privacy. It should be located at the above or below edges of the film and does not superimposing the region of interest. So in conclusion, this projection of epifemur is unacceptable because there is no name, ID, and date, and there is no marker, and there is evidence of rotation. This is my image of lateral femur. For the projection, this is a radiograph of a lateral projection of the femur. I say this is a projection of the femur because the mid-femoral shaft is at the center of the exposure field, and the head and neck of femur until the knee joint is included in exposure field. And I say this is a lateral femur projection because the anterior and posterior margins of both medial and lateral femoral condyles are aligned to each other. And also the lesser trochanter is in profile medially. So this is the positioning criteria for true lateral of distal femur. The anterior and posterior margins of the medial and lateral femoral condyles are aligned. We can see if there is a mispositioning by looking at the anterior and posterior femoral condyle alignment. If the patient's patella was situated too far away from the IR, the medial condyle will demonstrated posteriorly to the lateral condyle. And if the patient's patella was situated too close to the IR, the medial condyle demonstrated will be anteriorly to the lateral condyle. Next, this is the positioning criteria for true lateral of proximal femur. The lesser trochanter will be in profile medially and the femoral neck superimposes greater trochanter. We can detect if there is mispositioning by looking at the greater and lesser trochanter. If the leg and pelvis are not rotated enough to place the femoral epicondyles perpendicular, the greater trochanter is not positioned beneath the neck and head, but is partially demonstrated laterally. And the lateral trochanter is partially demonstrated medially. And if the leg and pelvis are rotated too much, the greater trochanter is partially demonstrated in profile medially. Can you see? And the lesser trochanter will be obscured by the femoral neck. So this is positioning for my image of lateral femur. The positioning for this projection is correct, meaning that the patient is in true lateral. I say so because the medial and lateral condyles are aligned to each other and the lesser trochanter is in profile medially and the femoral neck superimposes the greater trochanter. Next, for the alignment between the X-ray tube with cassette cannot be determined because there is no four borders of collimation, and the alignment between patient with cassette cannot be determined because there is no four borders of collimation, and the alignment between the X-ray tube with patient also cannot be determined because the X-ray, cassette, and patient is not aligned to each other. The long axis of the femoral shaft should be aligned with the long axis of the collimated field. The centering point for this radiograph cannot be determined because there is no four borders of collimation. The standard centering point for this projection should be at the midshaft of femur, here. Next, for the collimation, at the superior border, structures that should be included are greater trochanter, lesser trochanter, and femoral head. And at the inferior border, structures that should be included are femur condyles, patella, and distal femur. And at both lateral borders, structures that should be included are obturator foramen, tibia and fibula head, and patella. There is no evidence of radiation protection apparatus seen on the radiograph. For the exposure factor, the KVP used is adequate. This is because the bony cortical outline of the thin structure, which is the patella and lesser trochanter, can be seen, and the bony cortical outline of the thick structure, which is the distal femur and femoral head, also can be seen. And for the MAS, the MAS used is adequate because the bony trabecular pattern of the thin structure, which is the patella and the lesser trochanter, can be seen. And the bony trabecular pattern of the thick structure, which is the distal femur, and the femoral head can be seen. Therefore, there is no action needed to improve this. For the marker, there is no evidence of an anatomical marker shown in the radiograph. This is not a plumbar marker. It should be placed at the upper left or bottom right side of the body, and it should be placed appropriately and thus not superimposing any region of interest. For the aesthetic value, the film size used for this radiograph cannot be determined. The standard film size for this projection should be 35-43 cm, and there is no evidence of artifact on the radiograph. For the name, there is no ID and information of the patient. It is to protect the patient's privacy. It should be located at above or below edges of the film and thus not superimposing the region of interest. So in conclusion, this projection of lateral femur is unacceptable because there is no name, ID, date, and there is no marker, and there is a slight structure cut off. So this is my references that I've used to complete this presentation. That is all from me. I hope you understand I have what I have discussed. Thank you.